غير المغضوب عليهم ولا الضالين آمين. Ewe Mwenyezi Mungu, tunakuomba linde umpe. Ewe Mwenyezi Mungu, tunakuomba linde umpe afya na muongoze rais wetu. Tunakuomba umlinde na umpe muongozo mgeni wetu wa heshima leo, naibu wa rais. Tuongozee viongozi wetu wote, tuongezee taasisi zetu za nchi yetu. Mwenyezi Mungu, tunakuomba ipe nchi yetu afya na siha. Tunakuomba ibariki hili kongamano ili tuweze kupata afya nchini kwetu. Naomba yote kwa jina lako ewe Mwenyezi Mungu. Amin.
Let's continue praying. Almighty God, we come before you this morning with thanksgiving in our hearts. We want to pray for His Excellency the President, Dr. Samoei Ruto. Thank you for his leadership. I pray for the Deputy President, Professor Abraham Kindiki. Father God, I pray that you may bless him, guide him, because he's our chief of case right now. I pray, Lord, for the leaders present, that you may bless them and guide them, give them wisdom to lead this country to the next level. I pray for this summit, that you may bless all the delegates that have come from the counties. Guide us, Lord, until we end this summit as we continue now. We pray all this, Jehovah God, believing and trusting in Jesus' name. Amen.
Kwa ruhusa yako Mheshimiwa Naibu wa Rais, naomba tuketi. Mheshimiwa Naibu wa Rais, nikubalie tu kwa dakika mbili kwaya yetu ya SHA na kwaya yetu ya KIMSA wana ujumbe kwamba sisi sote tunaalikwa kuwa mabalozi wa amani. Kifungo kimoja tu, Mwalimu Emodia, Mungu nifanye chombo cha amani.
Mungu nifanye niwe chombo cha amani yako, nisambaze amani duniani kote. Mungu nifanye niwe chombo cha amani yako, nihubiri amani kwa Wakenya wote. Mungu nifanye niwe chombo cha amani yako, nisambaze amani duniani kote. Mungu nifanye niwe chombo cha amani yako, nihubiri amani kwa Wakenya wote.
Palipo chuki na ugomvi nilete upendo,
ili Wakenya wote waishi kwa upendo wa kweli.
Palipo chuki na ugomvi nilete amani,
ili Wakenya wote waishi kwa amani.
Popote palipo na mzozo nilete amani,
ili Wakenya wote waishi kwa umoja wa kweli.
Popote palipo na mzozo nilete amani,
ili Wakenya wote waishi kwa amani tele.
Yelele yelele,
Mungu nifanye niwe chombo cha amani yako, nisambaze amani duniani kote. Mungu nifanye niwe chombo cha amani yako, nihubiri amani kwa Wakenya wote.
Tupongeze kwaya yetu ya SHA chini ya Mwalimu Nike Modia na kwaya yetu ya KEMSA wakiwa chini ya Mwalimu Vincent wanapoondoka uwanjani. Shukran sana, tukishukuru waziri pamoja na wote ambao wamehusika kuhakikisha kwamba idara zetu mbalimbali zina kwaya ambazo ziko imara hivi. Profesa Kithure Kindiki, naibu wa rais, mgeni wetu rasmi, waziri wetu wa masuala ya afya Mheshimiwa Duale Aden, makatibu wetu ndugu Oluga na dada Muthoni, mwenyekiti wa jopo la magavana, gavana wetu Sakaja na magavana wote ambao wameshiriki siku ya leo, wajumbe ambao wako nasi siku ya leo pamoja na Director General wetu Bwana Daktari Amoth. Nikitambua itifaki zote na kuziheshimu, ni furaha yangu kuona kwamba mgeni rasmi yunasi hapa, na pasina kupoteza muda zaidi nitamwalika PS wetu wa lugha ili aweze kutuvalia njuga. Tumkaribishe PS wetu kwa makofi.
Your Excellency, the Deputy President, Professor Abraham Kithure Kindiki, Honorable Cabinet Secretary Aden Duale, Chair of the Council of Governors, Governor of Nairobi and all the governors present, our MPs, development partners, UN agencies, our staff from the Ministry of Health, and our staff from the county governments, all distinguished guests, ladies and gentlemen, good afternoon. It's my pleasure to welcome you to this session on the second day of the summit. Your Excellency, mine is just to brief you in very few minutes on what happened yesterday. Your Excellency, yesterday we had a plenary here where we opened the summit, laid the foundation, but also brought in the several discussions that were supposed to happen. And in the entire summit yesterday, the focus was on health financing. We also had a lot of discussions that went detailed into the social health insurance mechanism that we have, the social health authority claims, the SHA benefit packages, the revenue measures, issues around other investments, including the health infrastructure. Your Excellency, we also had a very detailed discussions on the digitization, and it became a huge enabler in terms of what has happened, particularly on the components of devices that have been given, the connectivity to internet for many public sector hospitals, and also the software systems. And we wrapped that with the use of data as a strategic asset. Your Excellency, we also had discussions that related to coordination between national government, county governments, and how we work together with our partners, multilateral and development partners. Your Excellency, this morning we came to the productivity of the nation, our mothers and our children. Her Excellency, the First Lady, Mama Rachel Ruto, was with us this morning discussing the issues that relate to mothers and children and the national agenda that is also being spearheaded by His Excellency, the President, that we call Every Woman, Every Newborn, Everywhere. Your Excellency, today we have combined 3 sessions to look at health workforce and how we move forward to establish a health workforce that is fit for the health system that we have reformed. We also will be discussing service delivery, how all of these components of healthcare financing, digitization, the healthcare infrastructure come together to the contact at the hospital level when patients seek care. And lastly, Your Excellency, is on the issues around commodity security and health products and technology. And Your Excellency, we are very privileged that you have joined us just for that session that combines those 3 strategic components of the healthcare system that we will delve in today. And later, Your Excellency, we will have a listening session in the afternoon. Your Excellency, we have had a very detailed discussion, apart from the plenaries, which we have been blessed to have His Excellency the President, yourself, Her Excellency the First Lady, Cabinet Secretaries, Principal Secretaries. We have also had 4 sessions that have been going on in parallel, and we've had an in-depth discussion, mainly at the technical level, and we have a very rich discussion. Your Excellency, having given that synopsis, now it is my pleasure to welcome the Cabinet Secretary just to introduce this session and take over the program, Your Excellency. Thank you, and welcome all of us to day 2 of the summit.
Your Excellency, the Deputy President of the Republic of Kenya, Professor Abraham Kithure Kindiki, Your Excellency, the Chair of the Council of Governors, the Vice Chair, the Chair of Health, and the many other governors, WHO Country Rep, Dr. Nema, colleagues from MOH, and colleagues from our county governments who work within the healthcare system, the chairs and members of the Health Committee of both Houses of Parliament, partners, donors, ladies and gentlemen, good afternoon. Your Excellency, my work is very simple. This session is bringing together three elements that make a very important contribution to the whole of the healthcare system. And they truly perform in such a way that if they are not working, then the healthcare system is not working. And these are healthcare service delivery. What goes on in our hospitals and health facilities, the healthcare workforce, and Your Excellency, when I came to the Ministry of Health, the first day, you and the President gave me that task. I was not welcomed to the Ministry of Health. There was no red carpet. I found the gate closed by demonstrating healthcare workers. And on a light touch, I asked P.S. Mudhoni, because P.S. Oluga by then was not there. I asked P.S. Mudhoni, fine, I will come in, but how do I go home after my duty? And she told me, no, you can pass through Kilimo House. There's an exit. And I told her, I am not going to pass through Kilimo House. My official gate is the gate of MOH. So the first day I started addressing healthcare workers, demonstrating. They baptized me, but I was very happy last night, at least both me and the Council of Governors, one thing they have agreed is that the last 2 years, we have resolved as a government all the industrial disputes working with the counties, from the posting of internship to the CBA agreements to UHC. So healthcare workforce is another thing that we are going to have and discuss in this session. The third one, which is important, is health products and technologies. We must discuss and we must get a solution to the historical issue in our country that hakuna madawa katika mahospitali na zahanati yetu. So, Your Excellency, service delivery is where reforms reaches the mwananchi through a very dependable primary health care, emergency response, surgery, mental and newborn and oncology and specialized care. The health workforce provides the knowledge, the skill, the compassion required to deliver that care, while the health product and technologies ensure that health workers have the medicine, they have the diagnostics, they have the equipment, and the supplies they require. Your Excellency, these three elements are inseparable. A trained healthcare worker without medicine or a functioning equipment cannot provide quality care. Commodities and technology without competent personnel cannot also save lives. An investment in either of these is meaningful only when the result is in an accessible, safe, and timely service for the patient. The effective integration of all these is therefore very central and timely for one important person, which is the patient. The effective integration is therefore central to improving our healthcare outcomes. It will be protecting families from financial hardship, and above all, it will strengthen our public confidence in our healthcare system. Your Excellency, as you have remained central to the coordination of government delivery agenda, and if I'm given an opportunity, I can speak for the Deputy President. I have seen many Deputy Presidents. I have seen many Vice Presidents before the enactment of the new Constitution. I have worked with the Deputy President in the legislature. He was the leader of majority of the Senate. I was the leader of majority of the National Assembly. We worked with him in the security sector. He was the Minister for Interior, and I was the Minister for Defense. So the person sitting before us, just in one word, not his position, not where he comes from, not his county, Kenya has a very decent in terms of personality in the name of Professor Kindiki. And that's why those of us who work with him in cabinet, that's why today I expect him not only to talk about these three themes, but of late, he is the one who does the summary of government achievement and programs the last 4 years. So as he gives us the highlights of this keynote address before we go to the panel, Your Excellency, as you used to do, I want you to start your summary from yesterday's plenary of the President. And you end it with what you have for us today. As we go now, later, with His Excellency, the listening session. So you have the opportunity to do that, Your Excellency. And now it's my distinct honor and privilege, colleagues and delegates, to stand up as we welcome His Excellency Professor Kindiki, the Deputy President of the Republic of Kenya, to deliver his keynote address.
Tafadhali naomba tuketi. Thank you very much, my brother Aden Duale. It is true we've traveled quite a journey, and I would also say the same about you. And the evidence is there to be seen, what you have done with the colleagues at the Ministry of Health to stabilize this very important sector. We needed a steady hand like Aden Duale to help us navigate the issues in the health sector. Makofi kwa waziri wetu. Brothers and sisters, I think I've been asked to do two things. The first one I'll do now, then I'll sit down, listen to the high-level panelists that are going to help us navigate the issues, the three issues that the minister has spoken about, and the PS. And after the panelists are done, I'll come back for less than 10-minute summary of yesterday and today. How you are able to condense 2 days program in 10 minutes, only Duale knows, because that is the assignment he has given me. But I'll try my best to do that. So allow me first just to set the stage for our panelists by saying the following: that His Excellency the President yesterday, in the morning and in the evening in the town hall, set out this direction of our national health reforms and the progress that we have made together as national government and county governments working in concert. My task during this session is much narrower than the President's overview that he gave us yesterday. I have been asked to focus on execution, on what must happen for the reforms in this sector to deliver consistently to the people of Kenya. And for that purpose, I invite you to consider a simple delivery equation, which is the right health workers, the equipment, which have the right products and technologies, and also delivery of the right services at the right time. Effective implementation requires a coordinated approach. I don't want to overemphasize the need for coordination. And I want to salute our brothers and sisters in the Council of Governors. Governor Abdullahi, the chairperson, and your team, we are very, very blessed to have this cohort among the Council of Governors. Between you and your predecessor, Governor Waigoro, the former chairperson, you have given President William Ruto and those of us in this administration support and unequivocal cooperation that could not have been possible without the right leadership at the Council of Governors. Let us appreciate our governors. So that coordination, I've been blessed to be part of that delivery by virtue of my work as chair of IBEC, which is the Intergovernmental Budget and Economic Council of the Republic of Kenya. And I'm again, in that role, I have had the privilege of working with the colleagues, ministers, members of the cabinet, PSAs in the various sectors, but also I have had the privilege of a very supportive Council of Governors who have made my work very easy. Again, let us applaud each one of us. So this coordination and cooperation has been very, very present. And the need for us to continue in that manner into the if one part of the equation fails, then the patient will feel that failure immediately. A trained healthcare worker without medicine cannot treat. Modern equipment without personnel or maintenance cannot provide health services. Financing cannot improve health if the facility is not ready to deliver care. Therefore, colleagues, brothers and sisters, the health system performance is therefore not just the total sum of individual programs. It is the reliability of the complete patient journey. We need one healthcare system with the citizens at the center. I'll be speaking to this a little more in my summary because we need this health system must deliver to the people of Kenya. If we do everything else and the system is not serving the people, we will not have achieved the objective. County governments are central to the success of this reform agenda through the implementation of the universal health coverage, strengthening primary health care, because they control the facilities in this space, the health facilities, and they control the entire frontline implementation and service delivery, the CHPs and also all the facilities up to level 5. Ladies and gentlemen, distinguished guests, that journey should begin at the household and at the primary healthcare facility before illness becomes severe and expensive. The primary healthcare fund, as we were told by His Excellency the President yesterday, has received 27 billion shillings, has paid out 23 billion shillings to more than 9,300 level 2 and level 3 facilities. Unprecedented. Every time I travel out of town, every time I accompany the President out of town, they are telling us that the amount of funding that dispensaries, level 2, level 3 facilities are receiving has never been received. I went to a dispensary somewhere in Kericho, in Sigoit Soin, and the governor there, Eric Mutai, was with me. And the dispensary told us this week we have received 1.4 million shillings from SHA this week. And they say in the past we never even received anything above 100,000, 50,000 at most under NHIF. So that's where we are. And this is money, as we are going to see, that is going to be retained to improve service delivery in that dispensary. It's not going to be sent elsewhere. This financing has supported more than 20 million outpatient visits by 15 million Kenyans. We have also increased primary care networks from 2 in 2022 to 278 hubs spread across the country. The fund is functioning. The next question is whether every shilling improves the facility's readiness and the patient's outcome. We must measure medicine availability, waiting times, early diagnosis, maternal and child health outcomes, and completed referrals. Primary health care must become the dependable front door of our health system, close to the people, capable of resolving most health needs, and connected to higher levels of care when timely referral is necessary. In that connection, it is important to note that we are improving, or we have improved how we respond to emergencies through the SHA 922 Lifeline and National Ambulance Dispatch Center. Kenya now has one national medical emergency number. One free call to this number connects a citizen to a trained dispatcher, an available ambulance, an appropriate facility and financing required for evacuation and the first 24 hours of emergency treatment. We must now make 922 dependable in every county so that we measure performance through calls that are timely answered, ambulance response that is timely so that it can save lives, appropriate referrals, and lives saved. In an emergency, geography and household income must not determine who survives. The same delivery discipline must guide the National Equipment Service Program, NESP. NESP is strengthening diagnostic imaging, theater, renal, laboratory, and other specialized services in county health facilities. His Excellency, the President, gave us the statistics yesterday, what kind of equipment, the value, and the program is ongoing, and it's across the country. Again, unprecedented. But equipment delivery is not the same as a service delivered. Our concern must be whether the equipment is functioning, whether trained personnel and consumables are available, and whether patients are receiving timely services. More than 500,000 surgical procedures and over 50,000 cancer care services have been supported through SHIF, the Social Health Insurance Fund, and Emergency Chronic and Critical Illnesses Fund, ECCIF. We must now build complete pathways in which screening leads to early diagnosis. Diagnosis leads to treatment, and treatment includes appropriate follow-up and rehabilitation for optimum health outcomes. Our ambition is not to own more machines. It is to shorten the distance, the time, and cost between a Kenyan and the care that can save their life. None of this is possible without health workers. Since 2022, again, the national government, in collaboration with the county governments, we have deployed 24,000 healthcare interns across all 47 counties. We've sponsored 262 medical registrars for specialist training, and we have committed now to recruit additional 5,000 nurses and midwives. Internship must remain. And this workforce is now supporting the 107,000 CHPs that are on the front line. So you can see already the progress that we are covering on the issue of personnel and healthcare workers. Internship must remain predictable, and properly supervised. But we must look beyond placement. National and county government needs one workforce plan connecting training, internship, recruitment, equitable deployment, career development, and retention. We must also train for the health system we are building, not the one we are leaving behind. That means strong competencies for the future areas of healthcare service delivery, which include primary health care, oncology, surgery, anesthesia, emergency medicine, critical care, biomedical engineering, and digital health. A health system cannot perform consistently when its workforce is managed through periodic emergencies. Our health workers must be planned and supported as a strategic national asset. I repeat, again, commending the fantastic work under CS Duale and our team in health, the COG, through the chair and the health committee and the entire leadership. We must continue to make sure there is stability within our healthcare workers. We cannot have a useful and progressive delivery system if our healthcare workers are disrupted from work. So we must build on this progress, and we have no excuse, we have no reason, we have no justification to allow disruption of healthcare service delivery. I must commend also the leadership of the healthcare worker unions. They have been very reasonable, and you have supported both county governments and the national government to find win-win situations to avoid disruption of service delivery. For the avoidance of doubt, we, the government of Kenya, national government and county governments, treat you, our healthcare service providers, as a strategic national asset. Brothers and sisters, ladies and gentlemen, the second condition for reliable delivery is commodity security. KEMSA's order fill rate, as we heard yesterday, has increased from 40% to 91%. And we have supported as national government KEMSA with 1.5 billion shillings directly, and also provided support for them to access a line of credit to the tune of 10 billion shillings. The next stage is to build an end-to-end supply chain that anticipates shortages before facilities run out. National procurement, county obligations, distribution and facility inventory must become one visible and accountable system. I was there when KEMSA and DHA were updating the president on where we are, and I think where we need to fine-tune now is the integration of the digitization process in KEMSA with the Digital Health Agency medical health data, so that it's one seamless. You know, you cannot have a digitized supply chain data that is separated from mainstream healthcare data. So the two are interlinked. So we need the two systems to speak to each other. And the supply chain and commodity supply chain data to be part of the whole under DHA. In the longer term, Kenya must manufacture more of the medicines, diagnostic medical devices, and offer products that we consume. Local manufacturing will secure our supplies, create skilled jobs, support innovation, and convert health expenditure into domestic economic opportunity. The reforms are in place and the investments are being made. What is now required is disciplined coordination across national government, county governments, agencies of government, providers, training institutions, partners, including implementing partners. We should leave this session today with a compact set of performance measures: facility readiness, equipment uptime, medicine availability, workforce coverage, waiting times, referral completion, patient safety, and health outcomes. Digitization must be the performance enabler that connects the patient's journey, gives us real-time visibility of health workforce, commodities, equipment, and referral pathways that enable timely correction and accountability wherever the system is off track. These measures should be visible by both the facilities and county governments. Strong performance should be recognized and shared. Persistent underperformance should trigger support, corrective action, and accountability. Our objective is straightforward: a health system that works the first time, works in every county, and works for every Kenyan. That is how we will move from policy pronouncement to programs, to performance, from investment to value, and from the promise of reform to reliable healthcare delivery. Thank you very much. I will be back with a summary, which should not take more than 10 minutes. I just thought I needed to make a pitch for all the issues and for the record of this conference to read a speech. Otherwise, when I come back, I will not bore you with reading any speech. Thank you very much.
Thank you very much, Your Excellency. Thank you very much. We may be seated. Your Excellency, allow me to practice. You know, you want us to be comprehensively competent. So before I call the panel, I just want to ask the crowd, Deputy President wetu ni fire si fire? Ni noma si noma? Summit ni fire si fire? Ni noma si noma? Your Excellency, you know I have to practice for a possible career. Your Excellency, at this juncture, with your permission and that of the Honorable Cabinet Secretary, allow me to call our panelists. I'll begin with the Vice Chair of the Council of Governors, His Excellency Muthomi Njuki, who is also the Governor of Tharaka Nithi. Please join us in this high-level panel discussion on HRH, HPT, and service delivery. I will also call on stage the Chair of the Committee of Health at the National Assembly, Honorable Dr. James Nyikal. Please join us. I am trying to look for Dr. James Nyikal. I will also call on stage the CEO of the Kenya Medical Supply Agency, Dr. Warko Ejesa. Please join us on stage. We have the chairman of the Healthcare Federation, Kenya Healthcare Federation, Dr. Gakombe. Please join us on stage. We also have representative of the UN agency, Dr. Neema Kimambo, who is the country representative for WHO. Please join us on stage. Yes, I can see Honorable Dr. Nyikal. Yes, and I will also call the CEO of one of our hospitals, Dr. Richard Lesiampe. Please join us on stage. And for the National Assembly, before we have Honorable Nyikal, who was around, I think we have a member of the Health Committee, Honorable Dr. Robert Bukose. Please, you can stand in for Dr. Nyikal. And Your Excellency, as the panel settles in the questions just as a prelude to the discussion on HRH, we have a State Department established for the first time in this government on professional standards. So allow me to call Madam Mary Mudhoni just for a 1-minute discussion on what this State Department has been able to do. Thank you.
Thank you very much, Daktari, Your Excellency. Karibu sana for our summit. Mine is just going to be a wrap-up of what generally we look at when we talk about HRH, or Human Resources for Health. And one of the key areas, and I know His Excellency Governor is going to talk about, is the requirement to deliver the right numbers. That is why the government is continually employing. Just the other day, we have been able to transition our UHC staff from contract to permanent and pensionable, and the counties every other time are employing to ensure that our facilities have the requisite numbers to treat the people of Kenya. Again, we are also talking about delivery of the right skills. From the State Department of Public Health, I keep telling the healthcare workers, niko na pesa ya kukupeleka shule. You only need to apply so that we can take you for postgraduate training. So do not just stay with your 1 degree. We can go and take you for specialized skills so that when you go back to your facility, you can add more value. We are talking about equitable distribution again. Just before we came in, we were talking about what we are going to do to get the needs assessment for the whole country, so that we are very clear on who we require in every county and every corner, and in all facilities. As we also send you for postgraduate training, we will be very keen to know how many OBS-GYNers are in Tharaka Nithi County versus the ones in Mombasa County as equivalent to the population. Then the fourth thing that we are going to listen to is the delivery of decent work and productivity. Management must address workforce challenges such as unemployment of trained professionals, issues to do with faculty gaps, issues to do with attrition, migration, and I am sure these are gaps that we have continually tried to address as we look into the structural limits, and that must be navigated while protecting the worker rights, safety, and also the well-being of our healthcare workers. And finally, deliver on the data-driven accountability. The whole of this summit, we've been talking about data, because data does not lie. And when you have the right data, you're able to also plan for the future. So Kenya has demonstrated a very growing capacity for evidence-based planning, ranking 3rd in Africa, and also 6th globally in national healthcare workforce accounts, reporting with 92% data availability. So with those few remarks, I take back the mic for the panel.
Thank you, Madam PS. And now we go straight in, which will be like a quick fire of just 30 minutes. And we begin with Your Excellency, Governor. The Constitution decentralized service delivery and established counties as the responsible level of government when it comes to management of health. Looking at where we have come from and the reforms that we have established, how do we enable coordination that ensures that national government, county governments strengthens service delivery at that level? And as you answer that question, you may also talk broadly about county public service boards and the role that they can play in strengthening health workforce, component as a part of health systems. Excellency, please proceed.
Thank you very much, P.S. Oluga. Of all the resources that we have put together as a government of Kenya to bring the health sector where we are, the most critical one is human resource, which sometimes we normally put at the bottom of the pyramid because it is a moving target most of the times as compared to all the other resources. It is possible for you to be able to tell how many drugs you've been able to move from KICC. You're able to tell how many equipments. But the management of human resource is so delicate because we are dealing with human beings who sometimes have responsibilities beyond the work that they're in. I say that because since devolution, which was supposed to bring services closer to the people, we've seen improved number, or rather we have seen number of health workers increasing in the counties as compared to before devolution. Not just increasing in number, but also in terms of quality and in terms of representation. And to give you a perspective on that, remote counties in Kenya before hardly used to retain very specialized health workers, especially the ones in the cadre of the ones we normally call the specialized consultants, where you find a remote county like Turkana used to have only 2 consultants. And those ones would hardly be permanently there because they have calls, maybe in the hospitals in Nairobi over the weekends, so they are in Turkana Monday and Tuesday, Wednesday they move. But since Turkana, I'm just giving Turkana as an example because we have the data that is amazing. Since we are given the responsibility to recruit, retain, motivate, and ensure that these specialists are meant for the Turkana people, they have seen the numbers rise from around 2 to over 20 specialists who are highly motivated, who are retained, and the Turkana people get value for their money. It is the same case across all the counties. Because when you manage your health workers, it is possible for you not just to monitor, but also have a responsibility as a team without being coordinated from somewhere else on your duties to be able to deliver. Secondly, we have seen increase the number of health workers in all counties since devolution. The number of nurses have increased, the number of clinic officers, the number of MOs. It is not just because of coordination, but because of deliberate effort by the leadership of the counties to fill in the gaps and also to adhere to WHO standards of the 5-kilometer radius of a health facility. And because of that, our patients are traveling shorter distances now to receive that care. Not just only to receive the care in the facilities, but for specialized, well-motivated healthcare workers who would usually respond to their needs. Do we have a challenge? Of course we do. One of the major challenges in that space is always having inadequate staff. Not because you don't need them, but because the capacity to hire them may be limited by the resources available. And even when the resources are available, we are limited by the established structure of the workforce, because we have a formula that does not allow you to have over 35% of your resources going to personal emoluments. So if you want to employ more staff in health sector and you need them and your physical space cannot allow it, you're only left to distributing the ones you have very thinly because you cannot ask for more resources unless you generate. Thanks to what is happening now in the space of health, since we had the reforms and the 4 laws that we passed, we have more resources now being generated through reimbursement of SHA, and with the facility improvement fund, we now have more resources that are available. But is it possible to direct those resources to employment? At the moment, I don't think the structure allows that. We plow that back to improve the facility. Does the facility improvement include employment? That is a good question we should be asking ourselves on the way forward, because that is also a need.
Thank you, Excellency Governor. I know time is limited, but I wanted you to comment on the intersection with the county public service boards. There are a number of counties that occasionally we find the county public service boards needs a bit of strengthening. The Constitution talks about the advisory role of Public Service Commission, but then how do we engage so that then service delivery is not interrupted?
The County Public Service Board have played a very critical role in recruitment, in ensuring that we don't just recruit, but to have the right staff with the right skills, and also being placed in the right places. And you are aware that even in the coordination that we have with the national government, the MOH, on the staff that we have shared responsibility, like the UHC, the recruitment was by the County Public Service Board, even though the payroll has been domiciled in MOH. Without the County Public Service Board playing the right role, we would be having these workers being somewhere in between without direct responsibility and supervision. Yes, it is true that we need to kit, or rather to continuously build our capacity for Public Service Board, because they may not currently be at the same level of Public Service Commission. But a lot of work has gone into capacity building, and we are seeing proper interpretation of policies from the MOH, and also in Salaries and Remuneration Commission, and also from Public Service Board, that have made the counties also be units of higher standards of professional recruitment in the workforce.
Thank you, Excellency. A round of applause for Excellency Governor. Now, on the same note of HRH, before we move to service delivery, we work with WHO at the Ministry of Health, and there are two key documents where the leadership led by Honorable Cabinet Secretary Aden Duale has been pushing us that we must have a health professionals policy. And this relates directly to how we galvanize the management of health workers from training. I know that WHO has had some input to the Ministry of Health, and as you mentioned, the role of WHO in intersecting with national governments that are member states of WHO in establishing policies for health professionals or even health workers. You may also comment on the Health and Care Compact, which is also another tool that involves a framework for enabling countries to clean up, let me use the word, clean up the space of health workers, because it's been a big challenge, including the code of practice for international recruitment of healthcare workers, just so that we wrap up that session on the health workforce.
Thank you very much, PS and Excellencies. I'll stand on existing protocol. So WHO has been working with the Ministry of Health on health workforce with support from the UK government. And I just want to highlight several tools that have been very useful. WHO has a tool called Health Labor Market Analysis, which enables the country to look at the different cadres they have, where they're placed, and look at the needs. And this health labor market analysis helps to look at the training, the production, and all the different cadres that you have and the needs of the country to enable the country to be able to plan with evidence for the health workforce. Another very important tool is the National Health Workforce Accounts, which helps the country to really come up with data of all the health workers they have. And prior to using the National Health Workforce Accounts, maybe we had numbers that were just at national level, but now we have detailed data that even counties, all the 47 counties, are able to see all the health workers that they have and where they are placed. And this is important because you're able to see the gaps and you're able to see where it is most important and where the gaps are, so that you place, as you recruit, that you place them in the correct places. And this was what P.S. Muthoni alluded to, that Kenya was ranked 3rd in the region and 6th in the world in terms of data. Another important tool is the workload indicator staffing need. This helps managers to be able to look at the load that the health facility is covering, what types of patients are coming in, and this then guides them to be able to plan appropriately based on the need of health workers. So we have been able to work with the ministry on this, and for the first time, the ministry has now come up with a health workforce policy and also a health workforce strategic investment plan. And at county level, about 130 managers, HR managers have been trained on this workload indicator staffing need, which will enable us to plan better in ensuring that we put health workers where they are most needed. And this brings in now the African Charter, which aims to ensure that we train, that we deploy, and that we retain health workers where they are needed, and to be efficient in our placement of health workers, because sometimes you can have the numbers, but you may have huge numbers, maybe in Nairobi, for example, and there's duplication, and you have other places which are more remote, which are lacking the services. This health labor market analysis also informs what P.S. Oluga has alluded to on the International Code of Migration of health workers. You are able to see what is your output, and are you able, countries are labeled according to their production, according to the staffing that they have, to see whether they can export health workers. Now, if you export health workers, what has been happening previously was in countries with good training, quality, you would have health workers being taken by developed countries, but the country that has been producing those health workers is not gaining anything. So at WHO, we work with countries to have, as they come into agreement with developing nations, as they are taking staff, that you have an organized migration, but you also get good contracts for those who are going, but also what comes back to the country, because the country has invested in training these people. So if they are going abroad, if you're producing more than you can use, but what is the country gaining? So WHO has been working with several countries, as well as I know Kenya, Ghana, Nigeria, and others in terms of helping countries to negotiate for this organized migration where needed. Thank you.
Thank you, Dr. Neema. Your Excellency, if you allow me, that the issue about the co-investment that WHO talks about is important for Kenya, because I know this is also one of the key agenda of our government. And I just wanted to ask for a roving mic, Your Excellency, just so that we get the numbers from KMTC in terms of nurses and those who are going abroad, so that then we can look at how to engage in this co-investment decision. And this is important for your leadership. So the CEO of KMTC, just a 1-minute comment on those numbers and how they have improved. Please, roving mic, CEO of KMTC is right here.
Thank you so much, Your Excellency. My name is Dr. Kelly Olwach, CEO of Kenya Medical Training College. Your Excellency, in 2022, we were graduating 15,000 students. In 2025, Your Excellency, we graduated 22,776 students. Your Excellency, that is an increment of 43%. Your Excellency, this year we are going to graduate 25,000 students. Your Excellency, one of the efforts that we need and very critical for us is responsible labor mobility. Your Excellency, as an institution, Kenya Medical Training College has created foreign language curricula in German, French, and Arabic, and now Amharic, to support labor migration. What Madam Nema is talking about is critical for Kenya Medical Training College because we are the largest producer of human resources for health in this country and sub-Saharan Africa. So we will want to engage to make sure that we're able to ensure that those we graduate are able to get gainful employment, not only locally, but internationally. Thank you, Your Excellency.
Thank you, Your Excellency. Just looks at some of the gains, and also I hope that our media, you recorded, you know, we are here for reforms that have been delivered. You recorded that Kenya is the 3rd in the world as far as health workforce data is concerned. I mean, the 3rd in the region and the 6th in the world. I'll move very quickly to service delivery. And here I will be asking from the private sector, Dr. Gakombe is here. 46% of the facilities now are private sector. The government has established the enabling frameworks for financing. How do we strengthen performance of service delivery at the private hospital level?
Thank you, PS Oruga, and allow me also to ride on existing protocols. It's true that the private sector is a key provider of care in the country. And because we must achieve access, achieve quality, and be efficient, one of the key things to achieve that, or one of the most enabling features or developments, is digitization. Because digitization allows all of us to keep track of what is happening across the entire country. And it allows us to tie all the facilities together, track referrals, and track outcomes, so that we can be outcome-based rather than purely focusing on the infrastructure available. And I want to take us back to a point when we had COVID. During COVID, the Ministry of Health scrambled to find ICU and critical care facilities. Today, that's not a problem anymore because SHA and the Medical Council and the ministry have live data on where that infrastructure is, whether it's occupied, and what is happening to the patients who are admitted in those facilities. Once we link up with the registration service so that we can record deaths and births on a live basis, we'll even go a step further so that outcomes can easily be tracked. So there is a lot that has happened, but one of the most critical is digitization, and the second one is the financing reforms. It's true we had NHIF, it had its challenges, we have SHA, and we've worked very hard to address some of the teething challenges SHA has. But for we in the private sector, payment comes from the patient. And many of them don't have money to pay. So having SHA pay their bills, having private insurance pay their bills, having employers pay their bills, enables more private sector service providers to thrive and grow. And for some of our patients, like dialysis, the only insurer and the only payer for the whole country is SHA. I do not know many places where there is anyone else paying for dialysis other than SHA, and the amount that is being paid is usually what we charge, because many of us are not charging anything beyond the SHA price. So we are keeping people who have end-stage renal failure alive through A, collecting money and channeling through SHA, and B, allowing private providers and paneling them as providers of service so that Kenyans have a lot more access.
Just in 1 minute, a very important thing. So His Excellency, the Deputy President, has just emphasized what the President mentioned about primary healthcare fund. Counties are here. They have made a lot of investment at that level, level 2, level 3, PHC, 27 billion, 23 billion paid. How do we shift the mindset of the private sector to invest in specialized services? 70% of PHC covered by government. We still do very less transplants. We still do very less cardiac surgeries. How do we shift the mindset of private sector that it is no longer very needed to just open up a clinic, pay very high rent, and see the same homa that the government has already invested at the village level? Just in 1 minute.
Our biggest job is to fill whatever gaps are left after the counties and the national government have provided service. So what you're anticipating is already happening. Many of our facilities, including the one I lead, are moving into more specialized care, renal, cancer, heart transplantation. And one of the key areas we are investing in, if you recall, that we've had a lot of traffic going out of country for treatment. And it's now policy that Kenyans should be treated here, close to home, near their relatives. That's a policy. And there is the money to finance it. So we are investing a lot more in upgrading care. I myself have brought the first robot for knee surgery in East and Central Africa, and we've already operated on 13 patients who would ordinarily have gone out of the country. And there are a couple more robots that have come in. So as KU does CyberKnife, Aga Khan is doing something else that is also quite specialized. We are doing something else which is quite specialized. And we'll be in Ethiopia on Thursday to tell them what it is that we can provide to them. So
Thank you.
We are regional.
Thank you so much. This is very important. And I'll bring in KNH. Yesterday you spoke in the town hall, you mentioned the establishment of the theater. So today, just tell us the outcome, the quality, and perhaps you bring in the technology, because KNH, you mentioned that is digitized for the first time, of course with the support of DHA. So just tell us, how has that improved? Two things. One, experiences of patients, and number two, outcomes.
Thank you very much, Dr. Oluga. Let me recognize the presence of His Excellency, the Deputy President. Kenyatta National Hospital is the second largest hospital in Africa. In fact, we still remember and say that it is the largest hospital south of the Sahara and north of the Limpopo River. And it has existed for 125 years. It has provided services for 125 years, you know, to this nation and also to the globe. When it comes to issues of specialized services, Kenyatta National Hospital with the University of Nairobi have not less than 500 specialists, you know, in almost every disease burden, 500. And we actually focus on specialized treatment. We are actually the apex of the referral system of our nation, and we are also the apex of research in medical spaces. So what we are saying is that we have several reforms that have taken place in the last 4 years. And one of them is digitization, automation, and embracing technology. And we are automating and digitizing, you know, the patient journey at Kenyatta National Hospital. From registration, triage, you know, the imaging, you know, to admission, theaters, you know, pharmacy, you know, up to discharge. And this has huge, you know, clinical outcomes. And in fact, has a great patient experience in the sense that patients will be seen, you know, on time. There will be no operational delays. You know, there will be less, you know, delays in payments, for example, in terms of SHA registration, in terms of SHA reimbursements, in terms of SHA claims. And therefore, that is one great thing that has taken place, you know, at KNH. We are not yet there, but we believe that in the next 1 or 2 months, we will actually conclude not only on the clinical digitization, but also in the back office digitization, where we actually bring on board an ERP system to manage the procurement, to manage finance and also manage HR. So I can also say that the last several years, we have managed to acquire, specialized, and modern equipment through the National Equipment Service Program. What in particular, when it comes to cancer, we now have 2 LINAC machines. It has never happened at KNH for the last, I think, the 125 years. We are also going to get another LINAC machine probably by end of September. We'll have 3 LINAC machines, high-level machines. These machines will definitely, create, great clinical outcomes for our patients. All patients who will come to Kenyatta National Hospital suffering from cancer, requiring cancer treatment, will indeed, benefit from this. And these clinical outcomes, will definitely demonstrate that our health system is working. We are also, in the sense of clinical outcomes, we have also acquired, modern ultrasound machines. We used to have 2. Today we are having 6 through the same National Equipment Service Program. This will also improve on the clinical outcomes when it comes to imaging. It will give us images, very fast images. The reports will be done very fast, and diagnosis will actually be done, additions made very, very fast. As I conclude, when it comes to issues of emergencies, I want to say that, through the ECCF, Kenyatta National Hospital receives almost all the patients who go through difficulties in Nairobi and in this country. All disasters are managed at Kenyatta National Hospital. All motor vehicle accidents, in particular, probably also managed at Kenyatta National Hospital. All fires that take place in our country, in most instances, they are managed at Kenyatta National Hospital. With the ECCIF, those patients now can access, free medication the first 24 hours, and from there we move them to NHIF. And this actually gives us, great outcomes in terms of management of our patients. As I conclude, we are the only national hospital or public referral hospital which has got golf carts. Our patients who cannot walk, our patients who are old and elderly, our patients who are, pregnant mothers, when they land at our Kenyatta National Hospital parking space, when they land there is a golf cart waiting for them. We carry them to navigate the whole hospital. From the bus stage, they are taken to the cancer center in those golf carts. They are moved from the cancer center to the diabetic spaces. They are also taken to the bus stage, back for them to travel back to their homes. There is no any other hospital globally, I think, in a public sector.
Thank you so much. A round of applause for Dr. Lesiampe. We now have golf carts. I think he must be responding to experiences of patients so that we make it easier. I will bring in the National Assembly. Your Excellency, Deputy President, as you are already very well aware, the government has pushed for 4 pieces of legislation. The only piece of legislation that relates to service delivery, quality of care bill, quality of care and patient safety bill is still in the National Assembly. We've done Primary Healthcare Act, we've done the Digital Health Act, we've done the Facility Improvement Financing Act, and of course we've done the Social Health Insurance Act. Now, at the level of interaction of all this equipment, of the medicine, of the healthcare worker bringing his knowledge and expertise to ensure that the patient goes home with their problem solved, there's something we call the Quality of Care and Patient Safety Bill. And this is the last piece of legislation. And I wanted, as we discuss service delivery, that Parliament could comment on their role and how they see this panning out. Thank you, Chair, and welcome for this plenary.
Thank you very much, acknowledging His Excellency, the Deputy President. Legislation is key in all these things that you have said. Eventually, if they have to be enforced, there's need for legislation. And as you have indicated, the 4 acts, particularly Primary Healthcare Act and the FIF Act, has had tremendous effect, and then NHIF on top of it. So now we have the Quality of Care Bill and Quality of Care and Patient Safety. Basically what this bill is attempting to do, or is planning to do, and which is supported, is actually to split
the regulation of personnel, the professionals, from the regulation facilities. I think that is the summary of it. And this is important because there's a lot of overlay that come together. And when you get that, then you can now say we regulate the personnel, the professional like this, and the facilities are regulated. And you know, there are a lot of issues that will come with the regulation facilities, how they are accredited, how they are empaneled, and so on. So that is important. This has actually passed through the National Assembly and is actually going to the Senate, and we are looking forward to it. What I know and the challenge that we'll face, and I think the minister is up to it, it is going to affect very many other acts, laws that are in place. And when we are looking at it, we looked at this, and I know very many professionals will come up, and the issues will have to be sorted out, and we must put a transition process which is very well worked out so that it doesn't bring clashes. But there's also one else, probably. We already have an authority act. Again, that is important if you are going to talk about medicines. We have the drug authority bill that is also in Parliament. It has passed through the National Assembly, is in the Senate, because that is going to be key if you are going to go in drug manufacturing. There is a need of a level that we need to, and that will be important. Again, that will be splitting the regulations of HPTs, health products and technologies, from the regulation of professionals. And I think all are important. So many things that we are looking at, Parliament is key. Another element we probably didn't ask is the area of appropriation. And I must really praise the government and the ministry, because where we have actually appropriated, we can see the results. And so with the National Assembly, in terms of legislation, and also in terms of appropriation, it's extremely important. That's all I can say for now.
Thank you so much. You know, Honorable Chair is a very senior health professional in this country. Please, let's clap for him for those very good comments. We want to move to the last session of health products and technology. We've heard a lot about KEMSA and the last mile delivery, and your clients are here today. Please don't dwell on the debt. Just dwell on how you can get the facilities to get medicine. And this thing, Waziri mentioned it in his remarks. How do we cure the disease of Hakuna Dawa Hospitali? And because the governors are here, and as you make very few comments, I will also be calling the chair of the Committee of Health just to wrap up on that bit about how do we ensure that last mile delivery before I bring back the CS to proceed with the program. So, Honorable Dr. Edjesa Wako, the floor is yours.
Thank you, PS. I recognize the presence of His Excellency, the Deputy President, and the protocols as established. Thank you. I think this is a very important discussion that we should have. Those of us who have done public health practice, there is the adage that goes, no commodities, no program. So whatever we do, if we don't have the final products, then we are not talking about health. So we take cognizance of that in KEMSA, and we said as part of universal health coverage, what can we do differently to cure this Hakuna Dawa syndrome in the head? So we sat, like 3 years ago, we sat and discussed and said, where do we need to hit? What are the high impact interventions? In life and in programs, you can do so many things, but what are the high impact interventions that we can hit to score, to move from 40s to 90s? Now, then we sat and said, KICC is not a traditional supplier that pushes boxes to facilities. Let us engage the counties, our customers, the facilities, and ask them what really matters to them. What do they require to give optimal services, and what do they need? What are the needs? Because we found a KICC struggling with buying a lot of things, quite a lot of things. Yes, it is good to buy so many things. I can be specific. We were chasing 3,800 SKUs. SKUs are stock keeping units, call them products, including technologies. Now we said, does the country require all this? To us, not. So we don't make decisions for our clients. Let us look at the trends. What have they been ordering over time? Then we realized they were ordering barely 500 items over the last 5 years. Yes, this is information available to us and in our systems. Let us corroborate this information with our clients. So we invited our clients. We had a national dialogue through the county pharmacist. I'm happy the governor has released all of them to come and discuss with us what are their needs. They actually confirmed our fears that KICC has been struggling with the limited resources to buy all these molecules, and we settled on those, and we said, let us buy those products. Then there's the traditional policy that a supply chain must hold 6 months of stock in its warehouse. Do we have money to keep 6 months of stock? We said, let us do what we call shrink and grow. Let us be realistic. Let us keep stocks for 3 months and churn around, because those are the small resources we have. So we decided to shrink and said, keep amoxicillin for 3 months, not for 6 months, because 6 months would be too expensive. So by smartly looking at the products and the time we need to keep our stocks, and we went into bulk buying. We went into bulk buying. So, it's different for you to buy things, and it's different for KICC to buy things in bulk. We get the economies of scale. We address the affordability issues. Then, because of time, I'll rush through. We looked at framework contracts. We found a KICC that was struggling to give contracts every year. So, before you realize, the contract is finished, and you have no supplies. So we went into framework contracts, minimum of 2 years, so that a supplier has a predictable deliveries that they make. So, and then digitization, finally. Digitization, very, very key. We have what you call an ILMS, which of course our Excellency, the Deputy President and the President and my Minister have always said we move to DHA, fine. But at the moment, we have the ILMIS, which has, let me just talk about one module called CWAS. CWAS is very good for us. Commodity Early Warning and Alert System. So at all levels, it will tell us where do we have stockouts or overstocks. Is KICC overkeeping? Are facilities also overkeeping? What are the optimal? So it gives us alert in terms of colors, to tell us, now there is a lot of stock at KICC. Can you offload this before you initiate procurement? I can see I'm being pushed for time. I recognize that, and I thank you very much. I'm ready for any questions.
Thank you. Thank you so much. Round of applause to all the panelists. Please, let's have our seats as we just have Governor Mudomi Njuki wrap up in just 2 minutes, please. And then you call CS Aden Duale to proceed with the program. Rest of panelists, we want to thank you so much. Let's have our seats.
Your Excellency, I just thought we'll not do justice to one aspect of human resource that we haven't spoken about, and that is coordination between the national government, that is MOH, and the county governments on the issue of human resource. And that coordination is what would really deliver the results that we desire and avoid the industrial arrest that we've had at the moment. Initially, we used to have situations where we had a standoff between the MOH and the counties on the issue of industrial unrest. But nowadays, Your Excellency, we sit and and burn midnight oil with the minister or the CS to ensure that we don't have any industrial arrest. That is where today, it's just been mentioned rightfully that for the last several years, we've not had many. I think the one Honorable Duale met when he was being inducted into the ministry could have been the first and the last one. But it is critical to mention that that coordination also has brought results that I cannot forget to mention, that the CHPs, initially when we had a standoff between who is paying and why can they not be paid from one kitty, the arrangement we have at the moment has produced results, has produced good results. Because when counties do not have their resources coming in good time, a national government pays. So the CHPs who are in this room knows, if the county has not paid on time, the national government will have paid, so I have money all the time. And it is a good thing because even their training has been well coordinated to deliver results. There's only one area on behalf of the governors that I want to request UCS on the training of our MOs, the postgraduate training. That we need to have need analysis when we take them for training, because sometimes we are taking training depending on the doctor's need, not the county or the employer's need. And also, we have a problem where when we take them for training, the counties continue paying salaries, and therefore we have gaps that have been left in human resource that we cannot able to address because we are paying people who are in Kenyatta National Hospital, Moi Teaching and Referral Hospital, KU, who are actually working there on training, and they have left gaps in our counties that we need to fill, but we can't fill because we don't have those resources. Our request or ask is that the national government or the ministry takes up both the training and the payment of salaries during that time, so that we can be left also to fill that gap by having short gap, maybe contracts for those who would wish to cover for 1 or 2 years, so that we do not have that gap. That is critical for us, so that we don't continue having gaps throughout, even as we continue training. Thank you very much. Honorable Duale, the CS.
You know, Your Excellency, your governor, he did not say, I inducted him to Parliament, I allocated him a committee of his choice, and later he became the chairman. So him and Governor Abdul Samad, Governor Mandago, now Senator, Dr. Pukose, and many others, when history is written, they must have a small paragraph or a page about me. Your Excellency, just to, because I don't want to speak, but just to react to what Governor Mudomi said on postgraduate students who leave county facilities and go to study. On one side, I'll agree with him, and we are in agreement that the speciality will not be decided by the doctor we are sending and paying for. It will be decided on what are the gaps missing in that county. Because we can have 3 people living in the county going to do the same course when that county requires an oncologist, when that county requires another specialty. So we are working with the DG, and we want to make sure that we put that in order. But paying them is a responsibility of county governments. But again, county government, Your Excellency, when they pay, the problem the county government face is this. Some of the students take longer period, 9 years. The county governments have to replace that person. Because by a HR person leaving means they must replace. So it's like they have to look for extra resources. But I think that is a matter we can discuss at IBEC between the 2 levels of government. This is above my paycheck. the person who deals with IBEC resources and how to balance the resources which are shared between the two levels is not the Minister for Health, is the Deputy President and the Chair of the Council with all of us. But I think it's a matter that we need to relook at. But I agree, and we have said, counties will say we need a pediatrician, we need an oncologist. So it should be, the need must come from that particular county. Different counties have different needs. Your Excellency, I don't want to go more than this. Me and you, we talk a lot in many years in Parliament with Abdul Samad and Mudomi. So I want you to come and wrap up. And I know your wrap up, those of us who have pens and papers, please take note, because the summary of the Deputy President is always based on data and factual, so that we can tell the people of Kenya. People are very happy online. I was seeing that they're saying this summit is very informative. So I think the Deputy will summarize for us. Your Excellency, it's my honor to invite you.
Asante sana, ni fire si fire. Let's keep it short. We've been here since yesterday, and I want to thank all of us. Of course, we are again having another session, which will be presided over by His Excellency the President, so that we can have takeaways. But allow me, in terms of delivery of government, both levels of government, to say we have made progress. In 2022, President William Ruto and the team that were campaigning for his election as president promised we will reform the healthcare system, something that we had struggled for many years without success because of the pushback by political interest, business interest, fraud and cartels that were benefiting from the misfortune of the people of Kenya by way of illness, profiteers, and all manner of characters. And the pushback has been there. Those of you conversant with Kenya's political discourse know President Mwai Kibaki, through Minister Charity Ngilu, tried this thing. There was pushback. We also know, those of us who have been following Kenyan political issues, President Uhuru Kenyatta, through, I think Kibaki was through Professor Anyang' Nyong'o, Uhuru Kenyatta through Charity Ngilu, or is it Charity Karaoke? So Sisiri Karaoke, I think. Tried under the Big Four agenda. UEC was there. Pushback. He gave up. So President Ruto said, we will reform this thing. Luckily, he expected the pushback would be there. But he promised the country that he will weather the storm, risk his popularity in the short term until we get this thing right, and his popularity will be back. Imefanyika, haijafanyika. The noises that you used to hear that SHA is not working, whoever is criticizing SHA now is whispering. But when we started, especially the initial months of rollout, it was terrible. You would think that Kenya has come to a standstill. How Kenya is a mess. By that time, we had not even activated some of the funds, like the ECCIF, the Emergency Chronic and Critical Illness Fund, was not operational. So there was chaos all over the place. But today, it is true there are people still who are criticizing, which is also okay because you just make us perfect things. Sometimes the only thing we ask is that you do it, those who are criticizing us should do it factually, not through generalities and through falsehoods. So this has been a heavy lifting of 4 years of hard work by the national government and county governments and the people of Kenya. We've made progress. And what we have said in the last 2 days, and we'll be concluding this afternoon, is there is still work to be done. We need to fine-tune things, but at least now, the framework and the system is in place. The program is now on its track. We just need to fine-tune a few things. What are the 5 things that we must now work on going forward? Number 1, the people. And I'm summarizing what we have said from yesterday morning. The people. The universal health coverage, Taifa Care, is about the health of the people of Kenya. So the bottom line is about the people. Better quality health care for the people of Kenya. How far have we come? From 8 million to 32.3 million today. Isn't that a great progress in terms of universality? Because we have had a healthcare program before. NHIF had a public medical insurance cover, but 8 million, 32.3 million, a huge leap, and still counting. I have been advised by those who are better than me in mathematics that we are now around 60% coverage. 32.3 million is about 60% coverage. If you add those Kenyans who are on a private medical insurance, we are approaching 60-something% coverage. That is not a small measure. Compare it with other countries for you to understand. Minister Duale and the team there, President Ruto, and all of us, when we visit other countries or leaders of other countries visit us, they're asking us, how did you get to pool by now 32 million Kenyans on UHC? And counting, because we must up the game. I am advised that 75% plus is what becomes universal health coverage. We are almost there. Some counties have achieved universality. I salute Governor Abdulswamad of Mombasa and 3 other colleagues of his who are now in the 70 plus, with Mombasa leading. It appeared impossible 4 years ago. Today, universality of health care is a reality because of numbers, the number of Kenyans who have some form of medical cover, which may not be perfect, which is being perfected, which is being fine-tuned, but at least when they fall sick, they do not have to rely on quacks, magicians, sorcerers, and manipulative religious leaders, some of whom take advantage of sick people. They have a medical cover. That is what universality looks like. We are smelling it. It's around the corner. Some counties have achieved it, others are on the way. So the target, therefore, we are hoping by the end of this year, we are talking about 40 million. By the time we go to the election, we should be talking about 45, 46. If you add the ones with private medical insurance, almost every person in this country will be having a medical insurance. Tuendelee tusiendelee. It is about the people. We must carry the people along. It was not possible under NHIF for someone without a job, without some ascertainable income source to be covered. Now, everybody, from the indigent to the poorest to whoever does not have anything, is eligible. That is transformation. And we applaud all of us for the progress this far. There is still work to be done. We've treated, you've heard the numbers, I think 20 million patients who have been treated in the primary health facilities. We've heard the money we have used. We've received 27 billion so far under the primary health care. We have disbursed 24 billion, and 67%, almost 70% of that money has gone to county government facilities under the primary health care fund. Today, the sustainability and the financing of private health, of public health facilities is now becoming a reality. We still have work to do to improve on that. The people, the numbers around the people of Kenya who are covered, what they are benefiting from, and the targets for the future is one of the things we must work towards, because these numbers are not just statistics, they are about human beings. And universality is about the numbers. Number two is the health workers. In 2022, we didn't have frontline health workers. Some counties had community health volunteers, others did not have. So President Ruto and the Council of Governors met and agreed to have uniformity. Today, we have an army of 107,000 community health promoters, paid a stipend, half by county governments, half by national governments, leading the war against disease in the villages and the households of Kenya. 107,000. And yesterday the President launched the next phase of replenishing their kits so that they can have better kits for testing and diagnosis and doing household health advice with better kits. We are also, the President has also talked about the possibility of us reviewing their stipend to make sure that we have a motivated frontline army. But we also have made progress. You saw in the statistics from the President, from myself, from the Minister, from the Council of Governors, that we have also, the national government has been able to post or to place 24,000 interns, medical interns, health workers, CHPs, medical interns, 262 registrars who have been facilitated to further their education and to specialize. But there is a commitment now which is being realized at the moment of hiring 5,000 nurses and midwives to protect especially our mothers, to make sure that we achieve that aspect of our health system. So about personnel. But we have also been able now to regularize the employment of 7,800 UHC staff. Again, work in progress. There are small things we need to fine tune, and we've just had a discussion with the chair COG. We have agreed what we need to do on that UHC to make it a seamless part of our healthcare worker system as possible. So the personnel, it's about the people, it's about the health workers. That's what we've been talking about the last 2 days. Number three is about the equipment. If you enroll people and give them a medical cover, and they have a medical health worker either coming at home as a CHP or in the hospital as a nurse or a doctor, that's not enough. And by the way, Governor Abdullahi of Wajir, the chair of the council, was telling me there were 800 doctors, now we are talking about 5,000 doctors. I didn't know. He was also telling me when he started in Wajir, the first time as governor, he had only one doctor at the main hospital in Wajir. Today, he has 70 doctors in Wajir, including 20 specialists within Wajir County. Is that correct, Mr. Chairman? Yeah. So that is what personnel issues, that is the journey we've covered, and it's still work in progress. But number 3, I said it's about equipment. You have the people, you have the health worker, but they need an interface called equipment. Therefore, through the National Equipment Support Program, we have placed so far equipment worth 9.8 billion shillings in 239 health facilities in 44 counties of the Republic of Kenya. And that work is ongoing. Equipment you will not have imagined. CT scans, the MRIs, the lab equipment, and so forth. There is a lot of equipment placement ongoing through a fee-for-service arrangement, whereby it is up to the person who owns the equipment to place the equipment, take care of the equipment, look for the consumables, make sure the equipment is working, maintain it, and the work of the patient is to come and get diagnosis. And once that diagnosis is done, the bill is sent to SHA, and SHA settles the bill. So it is up to the owners of the equipment to make sure the equipment is working, because if it's not working, they will not be paid. They are paid for every service that they deliver. So again, this equipment thing is work in progress. We have, looking forward, we need to work on level 2 and 3 a little more, so because that's where much of the early diagnosis is done. And I think that progress is something we need to be proud of. So you have the people, you have the health workers, you have the equipment. Number 4 is, and maybe this should have come earlier, the legal and institutional framework to deliver. Maybe it should have come earlier, after the people. The legal and institutional framework. That is why, and here we salute our Houses of Parliament, and we salute all of us for our various roles that we played to make sure that we have anchored this program under sound legal and institutional framework. Today, the laws are in place. The Primary Health Care Act, the Social Health Insurance Act, the Digital Health Act, and the FIFA, which is Facility Improvement Financing Act. You have the 4 laws. But we also have the funds, the 4 funds. Under the Facility Improvement Finance Act, you have the Facility Improvement Finance, which is retained at the facility to improve the quality, the service, the level of service. But we have the other 3 funds, the Primary Health Care Fund, the Social Health Insurance Fund, and the Emergency, Chronic, and Critical Illness Fund. Work in progress. But we also have the institutions. We have SHA, and we have the Digital Health Agency. That is the framework. And we are being told now, in terms of the future, of two legislations that are work in progress. One, and it was raised by the panelists, the high-level panelists who are here just now. One is the Quality of Care and Patient Safety Act, to make sure that this level of service delivery is standardized and of the highest quality. And then there's one which was mentioned by my senior here, Dr. Nyikal, the one on drug something, Kenya Drugs Authority Bill. Those two, so that if we go into manufacturing, as we should, as we have said we should, then that is the law that will help us fine-tune that area. That is the work around legal and institutional framework. 90% done, a little bit remaining to perfect it. Then, finally, number 5, it is the commodity logistics. We've heard what KEMSA is doing to improve drug supply. We've heard how we've moved from 40% to 90% in terms of availability of the drugs which have been requisitioned. But there is need for more work around KEMSA. And one of the suggestions that came from His Excellency the President, and I have repeated it here, is that the system which KEMSA is calling integrated something, medical, what is that MLIS something? Integrated, give him the mic. Integrated logistics.
Integrated Logistics Management Information System.
That system is good, but it must be interoperable with the data, the medical data under DHA. Because it's about supplying commodities for this system. So you cannot have all the other data separately in this data. The two systems must speak to each other. And that should happen sooner than later. And in the next IBEC, which is on Monday, or maybe the next one, some of the things we agree here, we should pick them up so that we start running with them. So about commodity supply, commodity logistics, we've made some progress. KEMSA was in disarray in 2022. We gave them 1.5 billion. We got them a line of credit of 10 billion, and we are happy with the good work that is ongoing there. But there is more work to be done around health commodities availability. But we have also 922, the National Ambulance Dispatch Center, an emergency number to provide ambulance services to patients who have emergencies, who have medical emergencies. You get the ambulance. First of all, the number is toll-free. That 922 is toll-free. Secondly, it should link you to the nearest available ambulance. And we must make sure the ambulance is available in good time to save lives. But also it is attached, that package is attached to emergency treatment. The first 24 hours of emergency treatment should not be pegged on anything. Whether someone has a cover under SHA or not, they must be stabilized as now they get registered into SHA and other things follow. So again, around commodity and medical logistics, the ambulances, the commodity availability of drugs and so forth is work in progress. Those are the 5 things: the people, the legal and institutional framework, the workers, the personnel, the equipment, medical equipment, and then the health commodities and logistics. With one enabler Those 5 things, we are fine-tuning them as we fine-tune the main enabler of those 5 pillars of our UHC is going to be digitization. The work that DHA is doing, technology, digitization of how we manage all these pillars is key and is work in progress. And this digitization will help us resolve the biggest threat, the biggest single threat to this program and to all medical insurance programs around the world: fraud. It is digitization and what DHA is doing that will help us fight fraud, because fraud interferes with the medical actuarials. Because the insurance is around actuarial estimates. How many people are paying how much? How many people get sick? What are the benefits like? What is being paid out? Fraud interferes with the health of the actuaries. So DHA has the solution. The sustainability factor is going to be around digitization, technology, and making sure that we fight fraud. Thank you very much. God bless you for your time, and I think we are in a good place. But there is a session coming at 2:30, around there the minister will announce what time, where His Excellency the President want to come and listen to what all the participants consider to be the takeaway. What is the take home? What is the experience? What is the agenda around the issues we are raising? Then he will give now the final strategic address, which will now send us back to our workstations. Ifaya. Minister Duale.
Thank you so much. Let's appreciate Prof. I'll request Your Excellency kindly to remain on stage. The rest of us kindly let's have a seat. Your Excellency, allow me only for 3 photos. The first photo, the ministry. I'll invite the CS, the 2 PSs, the Director General, and kindly for the first photo. Then the second photo, governors to be ready. So we'll have the first photo with the ministry as the choirs are taking their position. Let us balance. Let's balance like that. Thank you so much. The Kenya Health Summit 2026 reforms delivered health as a right. Thank you so much, governors. Governors, kindly join. Governors, Their Excellencies, governors led by the chair of the COG, the deputy chair, chair health. Karibuni sana. Thank you so much. A bit faster because His Excellency the Deputy would wish to receive the principal. Let's come forward a bit. Apa tu, Madam PS. Apa tu, tusiruke. That's better. That's better. Yeah, that's enough, Madam PS. Thank you so much. The last photo, all of us to leave and allow the Deputy President with the panelist. The rest of us kindly resume our seats. The Deputy President, Waziri na watu wake, Waziri na watu wako, the ministry, Waziri usiondoke tafadhali. Waziri, it is your role. And the panelist. The panelist. Let's do that. That's okay. The panelist. And that is our last photo so that we can give room to His Excellency to proceed to the other side. Thank you so much. All of us to leave and allow the Deputy President to remain on stage. The rest of us to leave the stage as I invite all of us to be upstanding. Niombe sote tusimame wima, walio na kofia ambazo si rasmi kuweza kuzitoa kwa ajili ya wimbo wa taifa. Thank you so much, Your Excellency. We've come to the closure of our function. Asanteni sana. We invite, as we leave His Excellency to leave, the rest of the VIPs will have a debrief at the opposite tent. All the other VIPs